Good morning, everyone, and welcome to today's Carer Knowledge Exchange interactive webinar, Getting Carer Data Right, Understanding What is Available and Why It Matters. My name is Sharon Gudu. I'm the Chief Executive Officer at Carers New South Wales, and it is my absolute pleasure to open today's session. This webinar has been developed with our wonderful facilitator, Nicholas, who you'll meet soon, and our guest speakers. And I'm delighted to see so many of you joining today, and I know there's still people making their way in. Before we begin, I would like to acknowledge the Gurulgal people of the Eora Nation, the traditional owners of the land where the office is located that I'm sitting at the moment, and would like to pay my respect to elders past and present, and also pay my respect to the traditional custodians of the lands where all of you are on today. And please do post in the chat the land that you are joining from. That would be lovely to see. I also extend that respect to all Aboriginal and Torres Strait Islander people who are with us here today. And I acknowledge also all Aboriginal and Torres Strait Islander carers across the nation. I'd just like to take a moment to welcome you and introduce myself as the new CEO of Carers New South Wales just before we begin. This is my 6th week in the job, and it's wonderful to be at this webinar so early in my journey in the organisation. I'm sure many of you know Elena Katrakis, who was here before, and she has left us after 19 years of wonderful leadership. I'm delighted to join this community and to support research and data that strengthens the experiences and outcomes of carers, an issue that we know is critical to the wellbeing of families, communities, and our care system. And we know that data and research is critical to make sure that our policy advocacy and our service delivery meets the needs of carers. So thank you all for your commitment to that. So about the Carer Knowledge Exchange, the CKE as we call it, which I'm sure many of you know about it, but just in case you're new to this, I'll provide a brief overview. The Carers Knowledge Exchange is a knowledge translation project led by Carers New South Wales with funding from the New South Wales Government. We aim to connect research to practice to improve outcomes for carers, and one of the main ways we do this is through interactive events such as today. I should also note that this project understands a carer as someone who provides care and support to a family member or friend who lives with a disability, mental illness, alcohol or drug dependency, chronic condition, terminal illness, or who is frail due to age. Today's session will be facilitated by Nicholas Smith, a carer for his mother and a valued member of the Carer Knowledge Exchange Steering Committee. Thank you again all for being part of today's webinar, and I'm sure you will get a lot out of it. I will now hand over to Nicholas, who will guide us through the discussion and introduce our guest speakers. Thanks, Nicholas.
Thanks, Sharon. And thanks for having me here today. So I'm Nick. I'll be facilitating today's session. Former carer for my mum with Alzheimer's and have recently transitioned back into the full-time workforce. And I'm a member of the Carer Knowledge Exchange Steering Committee. And this is definitely a topic near and dear to my heart in making sure that carers' voices are heard throughout all levels of policy and decision making and backed by data. So please note that today's session will be recorded and shared for on-demand viewing. We ask that the first hour of the webinar, everyone that is not part of the panel, please mute your microphones and turn off your cameras so we can focus on the panelists. We recognise that many carers and others with lived experience join these webinars. If you hear something that causes distress and you need to talk to someone, we have a wellbeing officer available online who you are able to contact. Further information on how to do so will be posted in the chat. In previous events, such as this year's Care Knowledge Exchange Research Incubator, and from conversations with policymakers and practitioners, we heard how critical data is for evidence-based policy making and improvement of practice. However, knowledge about, access to and navigation of care-related data remain fragmented. This webinar, we will explore what care-related data is available in Australia, highlighting why care data matters and how it can be applied to research, policy and practice. So our panelists today, who have graciously given up their time, I'll just run through a brief introduction of them now. So first, we have Louise York. Louise is the head of community services at the Australian Institute of Health and Welfare. This group is responsible for developing, collecting, analysing, and reporting national data in areas of people with disability, older Australians, and victims and predators of family, domestic, and sexual violence, dementia, palliative care, and income support. Louise has over 30 years' experience in developing evidence about the health and welfare of Australians. Welcome, Louise. And next we have Professor Rebecca Mitchell. Rebecca leads the Health and Societal Outcomes Research stream at the Australian Institute of Health Innovation at Macquarie University. She's a psychologist and injury epidemiologist. Her research focuses on large-scale epidemiology and mixed methods studies to guide improvements in health service delivery and health policy. She also has experience in implementation science, and evaluation studies. Great to have you here, Rebecca. And lastly, we have Madison Bick. Madison is a policy officer with Dementia Australia, the national peak body supporting people living with dementia, their families, and carers. Her background includes public health, statistics, and data analysis. She obtained a Masters of Public Health from the University College Cork in Ireland. We will first hear from Louise about how carers feature in the work of AIHW. Rebecca will then give us insights on how in their work she combines administrative data sources, qualitative data, and finally, Madison will give us insights on how Dementia Australia uses carer data in advocacy. After the presentation, we'll have a facilitated discussion before opening it up to all participants. If you'd like to ask a question, please post it in the chat at any time. We'll see to it as many of these questions get answered as possible. So I'll now hand over to Louise, who will share a brief presentation. Thank you.
Thanks very much for inviting me today to speak to you. I'm very happy to be here. And Nick, you've just explained who I am and the topic of my presentation. And before we get started, I also would like to acknowledge the traditional owners of the country that we're all meeting on today across Australia. I'm joining you from beautiful Ngunnawal country, and I'd like to pay my respect to the people, the cultures and elders past and present, and extend that respect to all First Nations people joining us today. So for those who don't know the AIHW, the Australian Institute of Health and Welfare, we are an independent Commonwealth statutory authority, and as Nick said, we specialise in data and reporting and making data more available for research, policy analysis, advocacy, and the public. And we do our work in collaboration with a wide range of stakeholders, always very keen to hear about what data people need and where the gaps are. Probably, and while some of our work is appropriation funded or funded directly by government, it's worth pointing out that about 2/3 of our work is funded through specific projects and programs where the different government departments, either Commonwealth and state fund us. And for example, most of the work that Nick mentioned that my group's responsible for is directly funded by the Commonwealth government. So through our work, of course, being so interested in health and human services and welfare, well-being of people, we're super conscious of the incredibly important role of carers and both in terms of the care provided and also the load that is taken off other formal services and the economic value of all of that care. And we're also aware of the high strategic interest in improving information about carers, but that while some information is collected in some surveys, carers are often, information about carers is rarely collected in most administrative data collections. So in terms of our current approach to reporting on carers, at the Institute. We don't have a dedicated funded work program, but as part of preparing for today, we've done a review of what reporting we do already have across our organisation about carers. And we've used that to do a quick audit of all of the data sources we're aware of. So I'm going to quickly run you through that today. I'm very happy for you to reuse these slides because there's probably a bit more information on the slides than I can get through today. And I guess the key message is that while we have pockets of information about carers available across lots of different areas, such as our dementia reporting, our disability reporting, and our aged care reporting, it is a pretty fragmented set of information. So I'm going to start now with running through some of the administrative data that's available to support understanding of carer experiences, and then I'll move on to survey data that's available. And I'll start with Centrelink payments data, which is an important source of information about people who apply for and are found eligible to receive carer-related payments. And it does collect a little bit of information also about the people for whom they care. This is an important data source because it supports some publications by both the Department of Social Services and the Institute and others about the numbers of people receiving the carer payments, carer-related payments. But the Department of Social Services also produces a person-level data collection called Data Over Multiple Individual Occurrences, or DOMINO, that's actually also then available for analysis on request, and it can be linked with other data, administrative and survey data, in the big linkage systems such as the ABS's Person Level Integrated Data Asset, or PLIDA, or the AHW's major linked data system, which is called the National Health Data Hub. And so that linkage infrastructure has also informed development of the National Disability Data Asset. So Centrelink data is really useful for the carers. It covers, it's a useful data source, but it covers at most about 680,000 carers. Another major source of administrative data is aged care data, and the HW has some large holdings of aged care data that are brought together in a set called the National Aged Care Data Clearinghouse, and in that data there are two key aspects that relate to carers. For all people who actually receive aged care services, there'll be some sort of assessment that will show whether they have a carer. And then for any carers who actually receive support themselves, in, say, for example, in the form of respite, there'll be a little bit more information about those carers and the types of service they receive through Commonwealth Home Support Program. And unfortunately for the other major program, the Home Care Packages Program, you would know that there was that the older person had a carer, but you wouldn't know anything more about whether that carer received respite. Okay, so now I'm going to move on to a series of surveys that capture information about carers, and I'll start with the Survey of Disability, Ageing and Carers, so the major ABS survey. And this is a really useful major source of information on carers, and it's where the 3 million carers prevalence estimate comes from. And then it also has really useful information about carer demographics, income and employment, health and wellbeing, etc. And we currently use this survey for reporting about the Australia's Disability Strategy Outcomes Framework, And so that's where the survey of disability, ageing and carers gives us sort of a long-term view and enables us to see that there's been a decline over time in the percentage of carers who are satisfied with carer assistance services. So that survey, the ESTAC, or the Survey of Disability, Ageing and Carers, is conducted every 3 to 4 years and historically up to 6 years in between surveys. So fortunately, in addition to that, the surveys that you're probably all very well aware of are the Carer Wellbeing Survey and National Carer Survey, conducted by Carers Australia and Carers New South Wales, respectively. And these provide more frequent information about carer health and wellbeing. And it's through these surveys that we can observe things like the rise in loneliness among carers over time. There's another survey that we're a bit less familiar with, but I thought was worth mentioning, is the National Disability Insurance Scheme, or the NDIS, Participant and Carer Family Outcomes Surveying. And it's through these surveys that each year participants and their carer and family, carers and family are asked to provide information about how they're progressing in terms of their own goals. So this is also a potentially very valuable source of information about carers. And another one that's coming online in that same theme is Australia's Disability Strategy Survey, which asks some questions about carers, unpaid carers. So now I'm just going to move on to a couple of longitudinal surveys, starting with the Australian Longitudinal Study of Women's Health. And these longitudinal surveys are particularly valuable. They're valuable in their own right, because they ask all sorts of questions about their target population, and the people can respond themselves and give their experiences, self-reported experiences. But they also are routinely linked to administrative data, so they can be used to look at outcomes that can be detected only through use of that administrative data, such as linkage through to Centrelink data or hospital admissions or use of the Medicare system, that sort of thing. And while the longitudinal study of women's health gives us really good insights into health outcomes, health and wellbeing outcomes for female carers, the surveys I have on the screen provide a different window for carers. The Household Income and Labour Dynamics in Australia survey, or HILDA, gives us really good insights into the employment and income outcomes for carers in that study. And the longitudinal study of Australian children enables researchers to look at the outcomes over time for young carers. Right, so I guess where we've gotten to from here is very, very important to have information about carers. Quite a lot of information is available about carers, but it is collected in lots of different ways and potentially with lots of different definitions. From our review, most of the data we looked at does relate pretty closely to the main Carer Recognition Act definition of a carer, with some slight variations. In particular, of course, the administrative data sources, such as the Centrelink data or the NDIS data, will take the definition of carer and then overlay eligibility requirements depending on their program. So, for example, Centrelink payments are means tested, and NDIS has age restrictions, and is very firmly related to disability, of course, and so that obviously limits restricts the carers that are visible in those collections. And similarly, the survey data may have some slight deviations, but often lines up reasonably closely to the core definition of a carer. So now I'll just move in closing to talk a little bit about the main data gaps and then the areas for data improvement that we're aware of. I guess in summary, there's lots of data, but we have, particularly compared to some other population groups, pretty limited access to routinely available information that presents a joined up view of carer pathways, experiences and outcomes across all of the life domains that are important to everyone. So across things like health, employment, financial security and housing. So while we do have identification of carers in quite a few surveys, we know that there is always can be limitations in terms of whether people respond and say that they are a carer, and that is particularly can be very exacerbated for some population groups such as First Nations or culturally and linguistically diverse communities who might be even less likely to self-identify in a survey as being a carer. And then, as I've run you through today, identification of carers in administrative data is obviously limited only to people who both apply for services or support and who are eligible for those services and support. So it's a restricted view of carers in the community, a narrow view. And then in addition to that, there are plenty of other service settings in which carers play an incredibly large role and where we have very little visibility, and that includes people with mental health conditions, dementia, and drug or alcohol dependency. So we think that data linkage, so pulling some of these data sources together using and trying to expand our capture of information about carers is part of the future way forward. And related to that, pushing for use of more standardised assessments to help with identification of carers could also be part of the forward solution. And we've seen some really good examples of that in Canada, where information is routinely collected about how carers are faring, and in particular carer distress for when people are caring for older people, and that information is publicly reported on a routine basis. Now, I'm conscious that I've actually maybe gone over by 1 minute, so I'll finally close just by saying there are some activities that are underway, and there's some activities that we think form part of the future, and I've listed those on this slide, but we can probably come back to that in the panel discussion if people are interested. Thanks.
Thanks, Louise, and for the work the Institute does. I know I rely heavily on it in the work that I do, and I have a whole section of my notes that is for links that I save to always refer back to. So thank you for that. I'll now pass over to Rebecca.
So I'm going to be talking today about using data about carers with my researcher university hat on. I'd also like to acknowledge the traditional custodians of the land where we're all meeting on today, whose cultures and customs have nurtured and continue to nurture our land since the dream time, and just wanted to pay my respects to the elders past and present, and who may be listening to the webinar today. I thought I'd just put in a few little grab shots of Macquarie University. It's updated a bit since the 1970s, all the concrete buildings that it used to have. So this is our wonderful campus now. a very modern take, and at the top right is our Macquarie University Hospital. So Louise has talked a lot about the quantitative data and the quantitative data sets that are available. And when I've got my research hat on, I'm often asked, or you're putting in to request research funding, so you're writing your own research grants, or you might be asked to put in a tender to do an evaluation relating to an activity for carers. And so what I tend to like to do is to have some quantitative data. So that's all the data sets, all the surveys or questionnaires, for example, that Louise has been describing. But also it's really informative to have some qualitative data. So if you can then get out and conduct some interviews with experts and with carers, you might want to conduct some focus groups or yarning circles with carers out in the community, consult a wide range of stakeholders. There's also opportunities sometimes to do policy reviews or a document analysis, or even direct observations. So for a lot of the work that I do, we use a mixed methods approach. So we'll use both data and interview responses. But in saying that, there's also the broader ecosystem through which, or within which, a carer sits. So I'm looking, if I'm wanting to conduct some research with carers or about carers, I'm also wanting to sit the carer within their particular ecosystem. So I'm quite interested in what person level factors or characteristics might affect a carer, what family influences or community-based influences might also have an impact. And are there any state or national policies, or even some international influences, that are going to have an impact on a carer and their ability to provide care? As well as that type of ecosystem, and as you've seen from the data sets that Louise showed you, there are many sorts of information that are available across all different sectors of the government. So, and it goes beyond any one government agency. So we can have health information, we can have information about education, about access to transport, about employment. But unfortunately, a lot of that information is still currently held in silos in different government departments. So for me, I'm trying to delve down into those silos and trying to get some of the information out, because we want to kind of see how best we can influence policies and practices, ideally through linking together the different government agencies and the different practices and services that they're offering for carers. But as well as looking at the ecosystem, as well as looking across government departments, we're also looking at different levels. So, for example, we might be looking at very high level at a macro view. You might be looking at federal government, looking at national short or long-term policies or services that support carers. At a meso level, we might be looking at different state and territory short or long-term services and what type of supports are happening at a state government level. And then locally, a lot of services now for carers are being provided by local community agencies and local support. And so then there's a third layer as well, looking at the micro level. So we're looking at ecosystems, we're looking across government sectors and agencies, and then we're looking almost at a tiered response, a macro, meso, and a micro level. And why do we need all this information? A lot of the time, and as you've seen from some of the reports, we're looking for how many people are involved in providing care. Is it paid care? Is it volunteer care? How much is it costing? But also, what are the cost savings of a lot of the voluntary carers as well? We're wanting to look then at issues that are affecting carers. If there is a particular adverse incident that's occurring, or if a particular service isn't rolled out correctly, we're wanting to have a look at, well, what's causing it? What can we do to fix it? We're wanting to identify some priorities for services or policies or different types of interventions or research that needs to be conducted. We can often use data to guide the development of different policies, different services or interventions, and good to evaluate and monitor the performance of services for carers over time, just to see that it's a consistent level of service and that it is a service that's providing the outcomes that a carer needs. We can also compare services over time as well and make sure that we are having locally and the state and national level have the best use and allocation of resources for carers. If it is a particular service, we can also evaluate to look at how effective that service is in providing what carers need. And we can also look at cost effectiveness of different types of services as well and compare different services. So Louise has already spoken a lot about the different types of surveys and data collections that are held nationally. I've just got some of them here as well that are available. But a lot of those data collections, as I've mentioned, they are in silos. It's now being broadened up a bit. And so what if we could start linking some of those siloed data collections together? And we can start doing that now through some initiatives of the Australian Institute of Health and Welfare. They've got the National data linkage hub, where a number of linked data collections are available. And there's also the Australian Bureau of Statistics has their person level integrated data asset, or PLIDA, that also has a number of linked data collections in it as well. This data is all very securely held, and we have to do special training as a researcher to be accredited to access and use that data. But a lot of that sort of information is now broadening out the type of research that we can do and the type of information that we can access to evaluate different types of services for carers. So I was going to give an example of one of the studies I have conducted, and it's using carers. It involved carers from the Pathway of Care longitudinal study. So it's actually a study looking at children who are in out-of-home care. But as part of that study of children, their foster and kinship carers were also surveyed at different waves from about 2011 to 2020. So there were 5 survey waves of carers that we linked together and we could have a look at. And so we were quite interested to have a look at what might be affecting the ability of carers to be able to provide adequate care, or that might affect their well-being. So as I said, it was a study designed particularly around children, and you can kind of see in this light mauvey purple on the right side, there's all these different data collections that were linked for children and were able to be accessed to look for the children's cohort. But right over here, I only had in the red box, I only had the carers' 5 waves of data that I could have a look at. So oftentimes when we are conducting research, there'll only be some survey information, but gee, it would have been great to have all this other information linked for carers. I would have been really interested to see what sort of health services that carers were having to use over time as well. So as I said, we were having a look for carers about what might affect their ability to provide their caregiving and what might affect their well-being. Often the carers who were responsible for children, the children had a lot of physical and mental health challenges. who were in their care. And so it meant a lot of visits to the GP and other professionals while the children were with them. We had quite a few kinship or relative carers. So they were often older, so grandparents who were involved in providing caregiving. A lot of the services weren't really tailored for those carers. And there are also some carers who had themselves poor physical and sometimes mental health and were not really linked into a lot of good social support networks, which we also found was quite crucial in the literature that we were looking at, to be able to provide a good caregiving and well-being. It kind of was seen to reduce some of the health effects and reduce the impact of some of the stressful life events that carers were also experiencing. And carers in this cohort were also had the ability to access particular formal training as well if they wished. I'm just going to focus on a few of the outcomes, but what we did find is that carers who were in paid employment, there was an increased likelihood of concern for their ability to provide care, and also carers who were looking after multiple children. There was we had a higher likelihood of concern for their ability to provide care and for their own well-being. In particular for kinship carers, they themselves were often experiencing stressful life events, and again that was affecting their ability to provide care. If they again had multiple children in their care, it was affecting their ability to provide care. But on the flip side, older carers were less likely to show signs of concern compared to the younger caregivers. So as well as that kind of quantitative data, we also had opportunities where carers could be able to provide their own information. So they could just write little comments in as well. And this is where we got some of our most rich data. So a lot of carers were saying, look, you know, we're employed, we don't have access to all these other services. I'm taking children to medical appointments. And it's quite also difficult to access childcare. A lot of the carers had limited social support networks, but where they were available, they were finding it really valuable, a really valuable emotional support. A big one that came up a lot of times was the need for short-term respite, especially due to life events that might be happening in the family if a carer was ill or if another member of the family was ill. And then for a lot of the children, as I mentioned earlier, they had a lot of health conditions, and some of the carers weren't provided with any medical history, and in some instances didn't have the child's Medicare card, so we're finding it very difficult to get assistance. But we had a few implications for policy and practice that were really practical for the New South Wales Department of Communities and Justice that we were working with. There was definitely more information needed, and particularly a lot of carers were unfamiliar with the type of services that were out there that were available to them. And so getting more information about what support was available, I think would also be a great initiative, and particularly getting some potential options available for short-term respite for carers due to them having to deal with other life events that are going on, and even just additional support at different critical times during caregiving. And I guess just to acknowledge that carers with minimal social support also need some further assistance. And I think that's also backed up in the data that Louise was talking about with carers experiencing loneliness. And I too had some implications and I guess informal recommendations for advances with carer data, and they're quite similar to Louise's as well. So again, being able to identify carers in some of the data sets that we have available, at the moment, it's very tricky to do. Getting the ability to access data, again, if you're dealing with the government silo, that can be very difficult. In terms of the data linkage, I'm a very pro data linkage, and I've used a lot of national and jurisdiction-based linked data, but the process and the timelines to get access, I've actually requested access to the AHW's National Health Data Hub back in March, and I'm still waiting. So, it's not a timely exercise. And using data in policy evaluation, a lot of times there's not the time series, or the data isn't collected. We don't really have any performance indicators around caring that we are able to monitor to see if better services are being provided or not. And there's not a lot of feedback loops that actually come back to carers and services. And I guess that's it from me. I just wanted to acknowledge some of the resources that I've used to prepare the presentation.
Thank you, Rebecca. Yes, it definitely seems that there's so many aspects that come into the caring role, and it really does take thinking about like a whole systems approach and linking those different silos and the collaboration that's involved. And that's great. That's why we're sort of having this conversation to highlight those, and also measuring things over time as well. It's not just measuring the data for the sake of data, it's taking action on it and then seeing how we can obviously improve the lives of carers through all those different methods that you touched on. So thank you. I'll now hand over to Madison. And while Madison gets set up, there are links being put in the chat as the presenters are going through. So keep an eye on that if there's anything that is of interest to you.
So thank you, Rebecca and Louise, for your presentations. I think you did a great job of setting the scene for how we use care data in systemic advocacy. So my name is Madison Vick, and I'm a policy officer at Dementia Australia on their policy and advocacy team. I'd also like to start by acknowledging the traditional custodians of the land I'm joining from today, the Ugambe people, and pay my respects to elders past and present. I also extend that respect to any Aboriginal and Torres Strait Islander people with us today. So Dementia Australia is the national peak body representing people living with dementia, their families, and their carers. Across the organization, we provide services, education, and support at the national and state level. We offer post-diagnostic support, care support, counseling, and we offer 24/7 support with our national dementia helpline. Within the policy and advocacy team specifically, we focus on creating system level change. So making sure that laws, policies, and services are responsive to the needs of people living with dementia, their families, and their carers. And today I'll be discussing how Dementia Australia uses care data to strengthen our advocacy, where the gaps limit us, and how we supplement those gaps through the lived experience of carers and people living with dementia. I just wanted to show Dementia Australia's strategic plan for the next 3 years, and ensuring carers are supported as part of our priority around empowering and supporting people impacted by all forms of dementia, which is enabled in part by our data and research. So dementia is an umbrella term for a group of progressive brain disorders that affect memory, thinking, communication, and behavior. And while the risk increases with age, dementia is not a normal part of aging and can also affect people under the age of 65. There are an estimated 1.7 million people involved in the care of someone with dementia. However, this estimate includes both paid and unpaid care. And there are currently over 400,000 Australians living with dementia, and this is projected to increase to over 1 million in the next 40 years, and dementia is now the leading cause of death. So my presentation focuses on informal, unpaid carers who are often a family member of someone living with dementia. And to give context to who carers of people with dementia are, the National Survey of Disability, Aging and Carers tells us that there are over 96,000 informal carers supporting someone with dementia in Australia. Around 69% of them are primary carers, which means they provide the majority of day-to-day support. The majority of carers are women, often spouses or adult children, and the intensity of care is significant, with 42% providing 60 hours or more of care per week. And other data sources like the National Care Survey show this is closer to 60% reporting more than 60 hours of care per week. So we can see how intensive caring is. Dementia carers also span both older and working age groups, which both have different needs. Many supporting someone with younger onset dementia. Caring starts during the busiest years of their life. They're working full-time, raising kids, paying off a mortgage. However, the majority of carers of people living with dementia are over the age of 65 and are dealing with their own health concerns at the time caring begins. And the experiences will be different between older carers and younger carers. Carers of people with dementia take on a wide range of responsibilities. They provide cognitive support, manage behavioral and emotional changes. They often provide supervision to keep the person they care for safe, as well as personal care like dressing, bathing, and eating. Carers also often coordinate healthcare appointments, manage medications, navigate multiple systems like aged care, health, and disability. Many also carry important legal and administrative roles like managing and enduring powers of attorney and guardianship, and most are doing this 7 days a week, 24/7. And because the caring role is so intensive and wide-ranging, and supports can be very difficult to access, the impact on carers' well-being are significant. This National Survey of Disability, Aging, and Carers shows that 41% of primary carers of people with dementia reduce their work hours or leave the workforce entirely because of the caring role. Navigating systems and accessing support is also a major challenge. Since dementia sits across aged care and the NDIS, carers often feel caught between systems that don't talk to each other. And even within each system, the process can be extremely complicated to get services. And this is evident in the data, with 1 in 3 carers of someone living with dementia reporting difficulty accessing supports. Psychological distress is really common for dementia carers. The National Carer Survey shows that 82% of carers of people living with dementia report moderate to very high levels of psychological distress. And isolation is also very common, with over half of carers of people with dementia feeling isolated. And despite the significant responsibility of caring and the massive economic contribution of unpaid care, many carers tell us they feel invisible or not recognized in their role by government. So given the impacts of caring, the next question is, how do we use the data to influence change for carers? And data gives weight and legitimacy to the lived experience and helps governments see the scale and impact of caring. The way we collect and use carer data impacts how policies are designed, how funding is allocated, and ultimately how carers are supported. We use carer data from a number of sources, which Louise mentioned earlier. The AHW, the SSTAC, Care Wellbeing Survey, and the National Carer Survey are our main sources of data that are dementia specific. And we use the available data as evidence for reform and to highlight inequities in access to services and supports. We also use the data to identify unmet need, whether it's lack of respite, long wait times for services, navigation challenges, or gaps in services entirely. Data is also essential for making the case for investment and funding for programs and services. The data also helps to shape and inform major reform processes, which here we have examples of what our advocacy actually produces in practice. So once we have evidence, we use that evidence to inform government submissions, position statements, discussion papers, awareness raising, media, all on particular policy issues. For example, we put together submissions to government on a number of care-related plans and strategies. For example, the National Care Strategy and the National Dementia Action Plan, where we use the data to highlight the nature and impact of caring for people with dementia, gaps in current policies and service, and use this to establish relevant recommendations. In the National Dementia Action Plan, now carers are explicitly recognized as a priority population, and an objective of the plan is dedicated to ensuring carers are recognized, supported, and able to sustain their role. The plan also acknowledges the gaps in existing carer data and calls for better national data sets to track carer experience. We also use data in our strategic communications, for example, Dementia Action Week, Carers Week, and we use data to shape public understanding through infographics, fact sheets, and reports that make these issues visible. But as much as we use the data in our advocacy, there are also challenges and gaps, which Louise has touched on all of these, so I'll just go over them briefly. But fragmented systems is one of them because data sits across aged care, disability, and health, making it difficult to get a full picture of carers of someone supporting someone with dementia. We also see under-identification of carers. So carers themselves are usually not explicitly identified in the data sets because most are focused on the person receiving services and not the carer. Also, most surveys are based on self-reporting, and some people may not identify themselves as carers for a number of reasons, but especially during the early stages of supporting someone with dementia, where they may just view themselves as a family member providing support. Timeliness is another issue because some data sets are released every 2 to 4 years, meaning the evidence can lag behind current changing policy environments, making it challenging to understand what carers are experiencing right now. And we also have invisible subgroups where the data is either thin or missing entirely. And this includes carers of people with younger onset dementia, Aboriginal and Torres Strait Islander carers, culturally and linguistically diverse carers, and carers in regional, rural, and remote areas. We don't have a lot of granularity on the subgroups when it comes to carers of people with dementia, which limits what we have available to use in our advocacy. Because of these data gaps, we can't rely on the quantitative data sets alone. Numbers will tell you what's happening, but only the carers can tell you why, how it impacts them, and what actually needs to change. One way we do this is consulting with people with lived experience. And this is achieved through our Dementia Advocates program, which is a national network of people living with dementia and carers who inform policy, research, and service design based on their lived experience. Our team works closely with advocates and consults with them through interviews, focus groups, surveys on key policy issues to capture experiences not visible in the numbers, and also gives us insight into subgroups that we can't see in the data. And the themes we gather from our consultations help turn the numbers into narratives that policymakers can respond to. The stories and experiences of our advocates are also used in other awareness-raising forums like our podcast, which is called Hold the Moment. And season 2 focuses on carers. It's a great podcast, so I would highly recommend it. And Nick here features on one of the episodes around navigating the healthcare system as a carer. And I wanted to give an example of how we use the data in practice. And one example of how we combine data and lived experience and advocacy is our work on access to respite for carers of people living with dementia. When we talk about respite, we're talking about short-term care that gives carers a break, and even a small amount of respite can make the difference between coping and burning out. And it's one of the supports that helps keep the person they care for at home safely for longer. And in the data, we can see that the National Carer Survey shows that both planned and emergency respite are the highest areas of unmet need for carers of people living with dementia. The Care Wellbeing Survey highlights significant barriers in access to respite, and these barriers are increasing each year. It also highlights that carers of people with dementia use respite more than any other condition. And both the Survey of Disability, Aging, and Caring and the Care Wellbeing Survey are seeing a decline in respite use despite the unmet need. And additionally, more recently, the Inspector General has also drawn attention to ongoing challenges with respite, particularly for people with complex needs or change behaviors that are associated with symptoms of dementia. And there are no national data sets to monitor the availability and use of respite services by people living with dementia. So these findings in the data are consistent with findings from our own consultations with advocates, staff, clients, that carers have repeatedly told us they don't know where to go for respite or how to access dementia-specific services, or that the respite isn't available when they need it. They continue to face a range of difficulties accessing respite care when the person they care for has complex care needs. Carers also report quality concerns about the available respite and the reluctance of people with dementia to attend these services. And the appropriateness and availability of respite for people with younger onset dementia is also a concern because services are built around the needs, routines, and interests of older adults. So when we bring together what the data tells us, what it can't tell us, along with what we hear consistently through lived experience, it becomes clear that this is an area where government action is needed. And these findings have prompted Dementia Australia to progress some joint advocacy work with Carers Australia to call on the government for a needs-based analysis of respite availability, because right now no one can see what exists, what the supply and demand looks like specifically for dementia. So we know carers of people with dementia are providing an incredible amount of support, and that the publicly available data, along with our consultations, have highlighted significant impacts of caring as well as significant gaps in services. And we use this information to advocate for improvements. But looking ahead, data improvement is a priority of the National Dementia Action Plan. So we are hopeful to see some improvements in carer data as well as improvement in carer outcomes. And these are my references. Thanks for having me. And I think there should be a link posted in the chat that links us to our submissions.
Thank you for that, Madison. And yes, I had a great experience telling my story about navigating the aged care system on episode 2. And I think it just highlights how important the work that Dementia Australia does in bridging that gap between lived experience to policy and then back down to improving the lives of carers with dementia. All right, so we'll just move on to the panel discussion now. So thank you all for sharing your insights on how you work with carer data. As we know, caring roles are highly personal and diverse experiences, yet collecting data brings these experiences together. So I think everyone should be showing up on the screen. There we go. All right, so from your work, is there something shared among carers that you've found in most of the data that you work with? Is there a common story that could be told with the data you are working with? Rebecca, you are up on the screen, so I can see you.
Okay.
So,
I guess for me, the common story that was coming out was the need for ongoing support, and especially where carers didn't have as much social support or a good social network available. Otherwise, they need some additional resources or networks set up. Easily accessible information about the services that are available for carers, and particularly the services they were eligible for. I think that came out quite a bit. And obviously too it's just been touched on as well, opportunities for short-term respite, and particularly when they themselves were under the weather, so when they were also feeling ill.
So is there anything else you want to add to that, Madison?
Well, aside from respite, I'd say that's one of the main issues we hear about, but lack of recognition is also another one that carers of people with dementia, they provide some of the highest unpaid hours of care, and the impact to their well-being is quite significant, but they don't feel recognized and supported in their role by government. So not being identified in the data is part of the problem, but they also aren't recognized as part of the care team, and their expertise about the person they care for is often overlooked in hospitals, within aged care and other system interactions. So the lack of recognition would be one of the main stories that we hear.
Thank you. Louise, did you have anything to add on in terms of the data and the recognition within the work you do?
Look, probably only to say that it's carers aren't well recognised in the data, and it's really important to get that recognition to be more visible. To try and improve the data. So nothing really more from me on that.
So with that, that sort of being one of the biggest issues, and the respite, I know from my experience, I struggled to find it as well. So what's missing within the respite or the recognition, like from a data collection point, or from using that data, or is it more of this the siloed approach which is causing issues?
Sorry.
Go for it, Louise.
No, sorry, I thought Madison was going to respond, but I think we're always trying to improve our access to siloed data. We try to improve access to any data that is collected. So, for example, in the aged care system, trying to improve access to any data that's available, and then advocate for filling some gaps. So the example of respite that I mentioned in my talk, it's in, say, for example, the home care packages program, there's no information available about what services are actually received once you're in that package. So we've got the strange situation where if you're on the Commonwealth Home Support Program, or your loved one is, then there's a little bit of information about whether you received respite, but not once you go into that next level. And I think, and there's probably very little information about how long you waited or what the quality or the acceptability of that respite was. So we are working with the Department of Health, Disability and Ageing on trying to improve data standards and availability across the aged care system. So that's a work in progress. But I think just continuing to advocate for what's really impacting carers and what information you need, that is really helpful from that point of view.
Right. Thank you. Rebecca or Madison? I think, Madison, you were about to start saying something before.
Louise touched on everything that I was about to say. But yeah, that would cover it. We just don't have visibility of the service use at the moment, and whether people are entering, how quickly people are entering residential aged care after being provided respite, whether respite services are being used as intended as short-term relief. That would be the main concern, which is why we are advocating for a respite demand study to get the visibility of access.
All right, thank you. I had so next sort of question is, it's mentioned that some carers may not identify as carers due to stigma. Is there any strategies that you found helpful when recruiting people who provide care for research that is respectful and inclusive? Rebecca, is that something in your research that you've sort of seen?
I haven't found that people are finding a stigma associated with caring. So we would generally advertise for people who are providing a caring role. We mightn't term people carers, but we would say people who are involved in providing a caring role in the community or to a relative or something like that. I haven't found it a stigma though. It's very altruistic type of activity. So
yeah, within that, is there still, like, are there different definitions that people use within, like, research or within policy that makes it actually difficult to identify who carers are? Like, when you're looking at data holistically?
Yeah, so I guess when we are looking at data, carers aren't really identified at all. So if I'm wanting to look at how many times a carer might have gone to hospital for their own health condition, let alone the person who they're looking after, we can't identify that unless you had a cohort of carers and then you were following them through longitudinally to see what their impact has been. So again, yeah, it's just difficult to identify people who are providing a caring role.
And do you see similar things, Madison, with the research that you have within the dementia carer space?
Well, within the publicly available data that we have access to, we know that some of the limitations with surveys is that people may not identify themselves as a carer, but with the direct work that we have with advocates, I know that there's work being involved to make that advocate pool more diverse and inclusive so that we do have a more representative group of advocates. But in terms of stigma, it hasn't been something I've come across directly in my work.
Thank you. And yeah, so Louise, with that, like, you showed like all these different data sets that, across the different institutes or government areas. Is that a difficulty? Is sort of actually pulling that all together and using similar definitions across all?
Yes, and I think that's why we, every 2 years we synthesize the available data we have and bring it together in an overview about informal care for our Australia's welfare report. So that's a legislated report to government, and that's an area where we also we use that to say what are the outstanding gaps. So that's really what I'm very interested to be hearing people's feedback, and I can see the chat trying to absorb some of it about some of the gaps. But I don't have any direct experience with stigma, but I just echo the view that if we can't see, people are not asked these questions when they go to receive mainstream services, because we probably all know, because we're not asked. So before you even get to any potential that you might not want to declare that you have a massive caring role for a family member with serious mental health conditions or whatever, you're just not asked in the first place. Yeah, to make it hard to cater for you.
Yes, it makes it hard to identify and then provide those services or the eligibility and put them on the right path to receive that support if they're able to. So within the data, are there areas that of the data regarding carers in their mental health and loss of support?
Not in the routine data that we look at, that we have access to. So, for example, when we look at mental health support, we look at hospital data, Medicare data, the specialist community services data, the mental health data, if people are accessing mental health services that the state funds. And to our knowledge, there's no information collected about the presence of a carer, let alone any information about that carer. And that's the same with people who might be accessing alcohol and drug treatment services. And of course, the people accessing those mental health services and drug treatment services are already a subset of people who have the problems that the carers are helping with. So no, there's poor visibility there as far as I can see.
Rebecca, has any of your research highlighted the loss of those supports and mental health issues?
I'm just thinking about the research that we did with the Pathways of Care longitudinal study. We couldn't really delve in to see the loss of support, but there were certainly some carers who were struggling around with their mental health and experiencing depression that we had identified in the cohort that we were working with. So, yeah.
Thank you. Madison, did you have anything to add regarding that with the work that you do?
Regarding loss of supports, that might be something that we hear from advocates, specifically advocates trying to get onto the NDIS or who are already NDIS participants with younger onset dementia. And that what we've interpreted is that it's based on the design of the NDIS. It's not created to support people with progressive neurological conditions. So we have heard reports of people losing supports.
Yeah. No, thank you. Yes, it is definitely a challenging road, the caring journey. Has anyone got experience with identifying carers within the education community, like young carers at school? Is there anything being done down that end of the?
I don't have experience with that. No.
No, not that I'm aware of. The only thing was the longitudinal study of Australian children. So, but that would only give you an idea of approximately how many young carers there might be. But education data is I think that's a really good source, but it's not easily accessible.
All right, thank you. So I suppose, moving on, we've touched on it a little bit, but how would you improve the way that data is collected for carers in the context that you work in? Sorry. Like the top three things that would improve the way that, you could be able to work with carer data. Madison, I'll start with you.
The top three things that come to my head would be just more visibility in the administrative data. So that would be more linked data sets and a more granular view of the different types of carers of people with dementia. Because the needs of someone with younger onset dementia and carers of someone with younger onset dementia are so different. So being able to get a more granular view on that.
I can
Thank you,
probably
Louise.
build on that, Nick.
Yeah.
So I think that's right. We need to see more information collected about the caring role. So about the fact that a person is a carer and some information about their role in a sensitive way, like that has to be worked out. But I think also Rebecca's point about then if data is collected, it needs to be accessible, and data sharing, and particularly data sharing for data linkage, is still really challenging in Australia, and there's a lot of work to try and resolve that. But it still takes a really long time and a lot of persistence. And I can tell there's a few researchers on the call who would have experienced, including you, Rebecca, who've experienced that, and we experience it as well, even in our organisation and within government. So yeah, data sharing, data collection, data sharing, the use of data we already have.
Thank you. Is there anything else you wanted to add to that, Rebecca? I know you've touched on a lot of those improvements, but yeah, if there's one thing that you could change today, what do you think that would be?
I think my single thing would be what Madison also touched on, was around identifying carers in routinely collected data sets. It would just make the job so much more easier to look at, the impact on carers of, caring for people, looking at carers or being able to identify carers who themselves were having health issues, chronic health issues, mental health issues, just even identifying the magnitude and the burden to society. So then we could see what type of resources and supports are needed in different locations. So just having that information would allow a greater direction of the services, I think.
Yeah, thank you. It's definitely, that visibility and just collaboration across all the different, there's just so many levels within that. Maybe a more specific one for you, Rebecca. Sorry, this is from the audience. I probably should have been saying that throughout. I've been weaving them in. Is there supports for grassroots organizations or smaller local communities to collect data within for carers?
I guess it would be depending on what purpose. So if you're collecting data to be able to know who are the local carers in the community and form a network or a community of practice and be able to give tips and support to each other, that would be, a great initiative. But then if you're like me and you're wanting to conduct research, well, then there's a whole other little layers of things that you need to address and go through and consider ethics and that type of thing. But yeah, having communities of practice out in the community of carers who can support each other, I think that's a great initiative.
That's great. And so, Madison, like on that, you obviously, you collect the data, hopefully impact policy and change, and then do you sort of like pass that back down through other organizations that, or local communities?
I'm not sure about to local communities or organizations, but we do have a feedback loop internally when we're consulting with advocates, and we have a bulletin that goes out quarterly to provide advocates with an overview of recent policy activities in our team and how we've consulted with advocates and how that's influenced potential outcomes.
Yes, so I should also say that I'm a Teachers Australia advocate, obviously, and that closing the loop is obviously really important to know that the feedback has been received and seeing where that's gone. So we're almost out of time. So I suppose I just wanted to end on what is the most important aspect for your work that you want to share with a researcher, practitioner, or policymaker who wants to work with carers about the data that is available, or about how to work with carers to collect data? Louise, I'll start with you.
Thanks, Nick. Look, I guess my most important measure is to keep sharing the insights that you have about lived experience. And as a data agency, we really are working hard to try and both engage with people with lived experience in every realm of our activity, and to try and reflect that alongside data in whatever way we can, because we know that is it's a lot more meaningful, and it's also a lot more compelling. So that's something from me, just the importance of placing data in context.
Madison or Rebecca, take it away.
I'm happy to go. I guess in the context of working with carers and people living with dementia, if you only rely on quantitative data, you don't get the full picture. So to truly understand carers and to design effective policies, you have to combine the quantitative data with meaningful consultation. And we have a guide that Dementia Australia has put together. It's called Half the Story. It should be, but it's been co-designed. It's a guide that's been co-designed with Living with Dementia and carers on how to engage meaningfully with people with lived experience. And it walks through what good consultation looks like and how to reduce barriers for participation and why closing the loop matters.
Thank you. And Rebecca, any final thoughts from the work that you do, the research space?
For me, similar to Madison, I'd be talking about thinking about what matters most to carers and policymakers to maybe more listen and learn, and the real importance of social networks and supports for carers. And I think, if we could start building communities of practice, neighbourhoods of practice, to provide that sort of support, I think that would be a great initiative.
Thank you very much, and thank you for your time this morning. And I suppose just some of the highlights it seems to come back to is just that data sharing, that data collection, and even before that is just being able to identify carers and how important that step is in then being able to have that cross collaboration. And we can see that everybody is really keen to work together to really improve the lives of carers all around Australia, whether it's the sharing your insights, placing the data in context, and then also just all the research, all the resources and research that's out there. So if you are a policymaker or a researcher, there's obviously great work that the Care Knowledge Exchange is doing, as well as all the links and information that was shared. So thank you to Madison, Rebecca, and Louise for today. And so just to wrap things up, if you are a carer participating today, we also want to communicate that your wellbeing is important to us. And if anything discussed today has been upsetting to you or you need additional support, some support information will be now appearing on the slide and in the chat. So as I sort of mentioned, don't forget to explore the Care Knowledge Exchange digital platform. You can browse and share carer-related research publications in our research library and watch short presentations from the Spotlight series. Links are available in the chat. To make sure you're notified about these next steps and receive the recording link, make sure you're subscribed to receive Care Knowledge Exchange email updates. Link and a subscription link will be appearing in the chat. Now, I want to bring this webinar to a formal close and thank everyone for attending and participating today, especially our panelists and carers who took the time to join us and share their insights with us. Thank you once again, and we'll see you next time.